Grace,
Hey,
Anastasia, just saw you. Lauren, turn on your camera, guys.
Okay, give me 1 second.
Yeah, no worries. All right, I'm going to share my screen. Thanks for coming. Exam 3 review. I don't have Professor Ford's information from last night, but I'm waiting on her recording and I'll post in all the sections. So you'll have that, right? And then there's one more on Sunday evening with Dr. Kopteros. Okay. Um, so I'm going to share my screen. Of course, this is the review. This is the study guide that I sent you. Okay. It was blank at the time. Okay. And the the expectation was that as you went through the last 3 weeks of class, weeks 7, 8, and 9, that you completed this. You took notes and documented, wrote down what were important aspects of this concepts to know. Okay. So I have filled it in for you with some information I think is important that will be covered on the exam for each of the concepts. Okay. Just want to go through the beginning cover page, right? This is the exam 3 is set up the same way exam 1 and 2 are. Okay. This exam covers weeks 7, 8, and 9. 50 questions, some multiple choice, some select all that apply, and some math. Okay, there is a time limit, 75 minutes. Okay, here's my suggestions for what to review. Single dose, calculate IV dose over time, calculate mils per hour. And if you see at the bottom of this study guide on the back, I've given you some cheat information of how to do what is on the first page. Okay, just a quick, simple review. And remember, if you struggle with math on your first 2 exams, you can go back to week 1, right? I provided you Professor Bogart's YouTube channel in which she does a really basic math review. Okay, just starting from scratch, basic calculations, basic conversions, calculating single doses, calculating mils per hour. It's not a long tutorial, but it's worth it if you struggle with math. Okay. Um, okay. So let's jump in. Week 7. Okay. Here are the things that you should be preparing for and studying. 1 second. I'm sorry. Okay. All right. So these are week 7 concepts. Infectious disease, prevention and control. Okay, I need you to review the ways to reduce the spread of infectious diseases, including contact precautions. So here you need to be reviewing what are contact precautions. Down here, what are droplet precautions? What are contact precautions? What are they? This is your
Um,
this is your review.
Mask, gloves, gowns, goggles if needed.
Okay. What are droplet precautions?
Mask, eyewear.
Okay. What kinds of clients would we be using droplet precautions for?
Uh,
Reese
Possibly
and
respiratory, I
Anastasia, jump
believe.
in here.
like COVID, like something with the cough.
What about TB?
hmm
TB.
So let's say how do you care for a TB patient? What are some priorities? Do you want them in a private room? Do you want them out walking
Yep.
around the hallways?
Not without a mask.
Do you want the N95 mask, the proper filter mask?
Yep.
Okay. So if any of these bullets come up and you don't have an understanding of them, you need to go back to your readings because all this is in your readings. Okay. So be prepared to identify protocol for caring for clients of TB. So if you need to go back and review that. Okay, review the epidemiological triangle. What was that? We went through that in class. What's the epidemiological triangle? We
Um,
have to have three parts.
Host, environment, and I forget the last one.
agent.
Agent. Yep. So remember your agent, what's the agent? That's the whatever infection's going on, right? Bacterial, viral, exposure to a chemical. Have to have an agent that infects a host, right? Remember, the host is us.
The host is the person. Yeah.
Right, right. And then certainly what the environment is. So we went through multiple scenarios in class. You know, the agent, is it a COVID? Is it influenza? Is it an exposure to anthrax? Is it whatever it is? Okay, the host is us. Are we healthy? Are we compromised? Are we unhealthy? Do we have other comorbidities? Is our age a factor? Is our gender a factor? Right? How healthy is the host to be able to handle whatever agent's coming their way, right?
Mhm.
And then we have to consider the environment. Is, like I said in class, is this a long-term care facility with a bunch of elderly patients? Well, that could pose more risk, right?
Yeah. How would it spread?
Yeah, yeah. So the environment is a factor in how all this comes together. Okay, so your agent, host, and environment. Okay, differences between epidemic and endemic. Epidemic, remember, it is in excess of what's expected. That's why COVID became an epidemic. Many more expected cases than were anticipated, right? But now COVID's or the flu, you could use the flu. We have flu seasons that they say is very high above normal. Okay, very high is of what's been expected. So some flu seasons, the flu may be in an epidemic mode, right? Endemic, it's going to be around. It's not going away. Okay, so COVID right now is in an endemic phase. The flu is in an endemic phase. It's always going to be around. Yes, do we have things to help us through those? Vaccines, staying healthy, not minimizing exposure, of course, but be able to identify the difference between epidemic and endemic. And we went through that extensively in class. Okay. With regards to HIV, TB, STDs, I'm pretty clear here. Okay. You need to review the assessment, diagnosis, treatment process for these infectious communicable diseases. Okay. Chlamydia, syphilis, herpes, HIV, testing. The most important thing about testing we talked about in class is that coming back to test in 12 weeks. Remember that? Okay. Hepatitis immunizations, TB, how to care for a TB patient, teaching points with regards to the HPV vaccine. That's all in your readings. We went through that in class, so hopefully you took notes and can fill in these little bullets. If you can't, you need to go back to your lecture, reading, notes. But these are all going to be asked about. All these infectious communicable diseases are going to be asked about on the next exam. Okay, and you don't need to know every single thing about every one of these, but how would you do an assessment? How is it diagnosed and how is it treated? Because remember, these exam questions, HESI questions, are all clinical judgment questions. The assumption, and Anastasia and I just talked about this, the assumption is you have the knowledge. Now you have to apply it into caring for a client with potential chlamydia, teaching a client about HIV testing. All right, it's all client focused. Okay, so those are the six infectious communicable diseases to be familiar with. Okay. Bioterrorism and disaster. What are the two types of disasters? And give me an example. What are the two types of disasters?
Um,
Is one like weather related?
Natural and
Yeah.
man-made,
man-made.
right? Natural disasters are things we don't have any control over. Hurricanes, tornadoes, floods. And then you have your man-made, which is considered human. We cause those. Fires, warfare, explosions, pollution, water contamination, man-made disasters. Okay, let's say we talked about as nurses working in the community, you would be expected to participate in all phases of a disaster, from preparation to impact to post-recovery. So let's say you're working with a community and you're reviewing teaching strategies for families on how to prepare a disaster kit. What were the important things that we were teaching families? We went through this in class. How many days do you have to have a food supply? 3. How often do you have to review the kit? Every 6 months, right? For anything expired, right? Making sure everybody in the family knows where the main power source shutoff is. Utilities shutoff, right? Remember talking about that in class? Okay, and then lastly, making sure everybody knows where this preparation kit is, right? Why do we think we do mass casualty exercises? What are the intended outcomes? You may participate in these in your workplace. What are they? What's a mass casualty exercise?
When there's a bunch of like hurt people and you have to like triage them in specific order.
Exactly. And the purpose is to be prepared for any kind of a disaster, right? That's why they're called exercises. Bringing everybody who's going to be involved in these mass casualty events together to do a mock disaster, right? How does everybody work together? What are the response times? How did it work? What were the areas of improvement that we need to think about and strategize how our next mock can be handled better? Right? Obviously the intended outcome is that everybody's working cohesively together. Because if you think about a big disaster, I mean, look at the most recent disaster with all that flooding in North Carolina. Look at how many resources had to come together to help that community. Those are the intended outcomes of a mass casualty exercise, is making sure that everybody comes together, knows their role, and supports the mission of helping people recover from disasters, right? Review the guidelines of when water can be safe to drink. What are the guidelines? What's up? Okay, you ready? I believe we went through this in class. Water being rendered safe to drink means a few things. We have to boil for 3 to 5 minutes. We treat with household bleach, 1 ml, which is about 16 drops per gallon. That's number 2. And then we need to drain the water from all the hot water tanks, commodes. Okay. So that answers that question of review guidelines of when water can be safe to drink. What about the protocols in caring for clients that have had an exposure to a chemical spill? Okay, specifically, vesicant agents. We're talking bioterrorism agents now. What I want you to know about vesicant agents, an example of that would be mustard gas and exposure. The primary systems that are going to be affected: eye, ocular, skin, and respiratory. The next agent would be a nerve agent. An example would be a sarin gas. Sarin is going to pose significant respiratory issues. Okay. And then a blood agent, say like anthrax. I'm sorry, cyanide. Okay. Cyanide is going to pose extreme risks to skin and respiratory. And this, again, this is all in your readings. Okay. Review nurses' role in the impact stage. So in the impact stage, let's say you're working in the community and you're part of working with clients that are in the impact stage as the disaster's happening. What do you think our role is? What's our most important role?
Safety, not trying to prevent further harm or death or casualties.
Exactly. Getting people to safety, right? Whether you're out on the streets or in a facility, getting people to safety. What are some examples of foodborne disasters, waterborne disasters, vector-borne disasters?
Could that
Foodborne.
be an issue with the crops?
Mm-hmm. Yeah, foodborne illnesses, salmonella poisoning, right, from eating uncooked food, waterborne. What are some waterborne illnesses? Those could be from drinking contaminated water. You know, we hear of cholera, giardia, right?
Yeah.
Vector-borne illnesses, Lyme disease, malaria. And then review anthrax, smallpox, and sarin. We already covered sarin, respiratory complications, severe respiratory distress. We covered sarin, nerve agents, so we've already covered that. So be familiar with these three: anthrax, smallpox, and sarin. You can go back to your HESI prep and look at your anthrax. Week 8, we covered home care. Here's what I want you to know about home care for the exam. All right, what's the difference between home health and acute care? What's the main difference? Where are we providing the care?
Yeah. Is acute usually like in a facility?
Yeah, in a facility. So what's the difference between what is home care? There's two huge facts about home care. Okay, we are
It's in
providing the client care in their own environment, and it is
No.
individualized care. It's not caring for a group of people or a part of the population. Okay, it's individualized care in the patient's home environment. Excuse me. Review the review the process of a home care assessment. Why is a home care assessment so different than an acute care setting assessment? What's the difference? What's the big difference?
They're in their home. You have to like look at everything that's around them.
Yep.
And things that could be a hazard to them that they
Yep.
may not even be aware of.
Remember, you're their guest, right? you have to establish that trusting therapeutic relationship. You are their guest. And there's so many more things, like you started to say, to assess, right? Nurse must earn the trust of the family and establish a partnership with the family. It may just be the client, but maybe there's extended family members, friends, relatives that live in the home or are participating in the care, right? Not only does your home visit, it is known that home visits are one of the most effective ways to assess the whole picture of a client. Even though you may be going in to do, let's say, a medication check, you're also really doing a safety check, right? Environmental check, risk assessment, observing family dynamics,
Mhm.
right? Assessing equipment. Is it working? Is it not working? Supplies. Do they have the right amount of supplies? A home visit encompasses so much more than what you're originally going for, right? You
Yeah.
have the opportunity to do lots of different assessments.
How do you document if you think there's if they're having heating issues? If it's like the winter time and if their furnace might be broke or out, would you just say it just like that and try
Well,
to find this?
I mean, let's say you do a home assessment when you're doing your visit and you notice all of these things that are going wrong. I would document that, maybe bring it back to your home health agency, and then try and help problem solve how to get these things done. If you notice that there are risks, you can maybe enlist the help of the family members. The furnace isn't working. Who needs to be called if family members can help,
Okay.
right?
Yeah.
It's hard to answer that
Yeah,
question
yeah. And I guess you can
black and
get
white.
support. Yeah, you can
Every
always get support.
every situation is different, but obviously part of your assessment includes follow-up, right? If you've identified that, let's say they have a bunch of rugs around the house that they're going to slip on, well, you can remove those, tuck them away. Let's say there's a whole bunch of furniture everywhere and they're at risk for falling. You can move that furniture, right? Um, Review the importance of collaboration with multiple agencies when planning the transition from acute care to home. Think of all that needs to happen as clients are preparing for a transition from A to B. Here it says acute care to home. It could be home to acute care. It could be long-term facility, hospital, acute care to a long-term care facility, right? Acute care to a hospice facility. It's all about the transition. Okay. Think of how much needs to be. This is where case management comes in. We'll talk about case management in a minute, right? But why is collaboration with all these resources and agencies so important when you're planning transitions? Why is that important?
Because well, if they're going home, you want to make sure they have everything they need from transportation from the facility to
Exactly.
home, equipments they may need,
Supplies.
home care
Yeah.
set up.
Yeah. So home care requires an inordinate amount of collaboration. Okay. Review the importance of telehealth technology and how it relates to home care. Well, a lot of home care visits now are substituted with telehealth, virtual visits, right? So we can help the client get organized and set up for that. Okay. Review the steps and interventions when doing a safety and fall risk. What are you going to be looking at? Kind of already talked about that, but what kinds of things you're going to be looking for with
Yeah,
regards to
core
safety?
rugs, just clutter.
Exactly. Exactly. Review the difference between Medicaid and Medicare, Omaha documentation system. The Omaha documentation system was set up decades ago by the visiting nurses. I talked about this in class. And it is a charting documentation system in which it allows all caregivers, everybody who's involved in this client's care, agencies, workers, physicians, nurses, to provide a chart so that everybody can see what everybody's doing. So we try and minimize duplication, minimize overlap. So that's the Omaha system. It is used for home health. Medicaid, Medicare. When you're talking about home health, the big difference is skilled nursing care, right? There has to be Medicare, Medicaid is not going to cover your aid functions, your activities of daily living. They cover skilled nursing, changing a dressing, providing an IV, drawing blood, medication check. That's what they're going to be covering. I covered the Omaha system. Let me make sure I'm not missing anything on Medicare. Medicare has significant influence over the home health industry. Most of the home health guidelines, laws, rules, coverage, reimbursement is all directed by Medicare standards. And that's where the skilled nursing care comes in. Okay. Community resources. We talked about this briefly in class. As community nurses, we have to be educated and knowledgeable about community resources, right? Because every client, family, part of the community that you're going to be working with is going to need different kinds of resources, right? All the way from transportation to sitter services, maybe dog walking, right? Food bank, clothing bank, domestic violence shelters, homeless shelters. Meals on Wheels, right? So simply what I want you to know about community resources is having the ability to be able to provide resources in a variety of settings. Okay, what do you do when you're caring for non-English speaking population? And what resources might be available to them? What do you do? Who might you seek out for help?
Translators,
Community leaders, trusted people in the community that maybe are working with a population. I know that I had an example in the schools where there was a huge influx of a Vietnamese population. And they were all and lived in one area of this community. And in order for me to get information to these parents, I mean, we had interpreters in the schools, but it was on a very limited basis. One of the parents gave me the name of a liaison in the community, a Vietnamese liaison that was helping them all get set up, housing, food, whatever the kids needed, getting them the resources they needed. I reached out to this gentleman, and we ended up developing a pretty incredible close bond, where he was able to help me facilitate what the needs of the school were to be able to accommodate all the needs of that non-English speaking community with the schools. It was incredibly helpful. But those people exist in the community working with populations of non-English speaking groups. And yeah, I had a direct experience with that, and it was invaluable. I could not have connected with this community not knowing a whole lot about them, certainly not speaking the language, without this liaison in the community to help make the transition of these kids into the school setting. So, let's see. Community resources are used to enhance self-care, manage complex chronic illnesses, reduce vulnerability, right? So health departments, again, these are just resources. Health departments, nonprofit organizations, volunteer organizations, Red Cross. We talked about food and clothing banks. Crisis pregnancy centers is another one. Shelters for domestic abuse, churches. Okay. Case management. Okay, what's a case manager? What does a case manager do?
They kind of manage and facilitate and like oversee the patient's like record, whatever all their needs. They're like a resource for sure, I guess. But like a
Yeah.
number one resource, they kind of can get. They have access to all kind of different things.
They're
And
like a
he-
liaison for the
Exactly.
patients getting set up with community services.
They're coordinators of care. And you find case managers in most settings, insurance companies, hospital settings, home health agencies, oncology practices, a lot of case managers in practice that work with physicians to help them manage all the needs that their clients are going to have, right? One of the important aspects of case management is although we would like to case manage every client, it's impossible. The resources just aren't there. So case management is usually used with the very high needs, high complex, chronic illness, dual diagnosis, utilization of resources clients, right? Because those types of clients do rely on numerous resources, may require numerous medications, may need numerous hospitalizations or whatever their treatment regimen is. So as case managers help to coordinate all that care. Okay. It's individualized. It requires an incredible amount of good communication skills, good decision-making skills, good organizational skills. Because think about, and you probably know, family member, friend, somebody in the community that is a very high complex health case, right? I do. I have several that I'm aware of in my immediate circle that are very high complex needs. And they have case managers. And those case managers coordinate everything for them. Right. And the hope is to manage the costs. I mean, certainly effective healthy outcomes, that's the goal. But case management can also be extremely expensive, or clients can be extremely expensive, right? And case managers try and encompass all of the needs and trying to accomplish what is the best possible health outcome in the most cost efficient way. Okay. So the second bullet, reviewing the issues that can arise from fragmentation of services when case managing clients. Yes, there's a lot of fragmentation of services, broken down communication. I mean, it's not perfect. The system's not perfect. But there are overlaps, there are communication issues, there are documentation issues. Case manager tries to work through all of that. We talked about what types of clients would benefit from case management. Different styles of communication. Okay, so there's 4 styles of communication that we generally talk about with case management: collaboration, assertiveness, cooperation, and compromise. Okay, so with collaboration, you are working with others towards solutions that satisfy both needs of the party, both parties. Assertiveness, you're putting forth your own observations, your own desires, your own outcomes. That's being assertive. Cooperation, the ability to understand and meet the needs of others. You're trying to cooperate. Okay. And then when we talk about a communication style of compromising, and the case manager may need to use all four of these. Compromising is essentially finding mutually acceptable solutions that satisfy both parties. It may not be the ultimate of what you wanted, but you're compromising. You're coming to a basic, mutual, acceptable solution that is acceptable. Okay. Just a case management can be labor intensive, time consuming, and costly because of the increasing number of clients with complex problems, caseloads, and intensity is exceeding the demands of how many case managers we have, right? Health agencies continue to employ more case managers as the cost increases. We just talked about that. Right. So as case managers, some of our roles of nurse as a nurse, advocating for the clients, or the care coordinator, and we also are the referral agent, right? We're doing different referrals for whatever needs the client may have. Okay. Okay. Here are the complex chronically ill. Okay. There's a whole list right here. This was all from your readings. Cirrhosis, COPD, diabetes, PAD, CVI, and hypertension. Those are the complex chronic illnesses. And I've asked you to review the nursing process when planning care with these clients. Okay, so you can do that from all this information is in your reading. What is cirrhosis? How do you plan care? What do they need? Okay, so review assessment, diagnosis, treatment, process of wounds, wound healing. What are the stages of wound healing? When are you turning patients? When are you changing dressings?
I mean, you turn patients every 2 hours.
Okay, what if they have a sore?
It's every hour, isn't it?
Yes, it is. Remember that. Okay, typically we turn patients every 2 hours, but what if they have a sore? That bumps up to 1 hour, right? Okay, good. Review the guidelines for preventing complications in post-op settings, right? Obviously, we're looking in the post-op area, we're looking at circulation issues, pain management issues, nausea, vomiting, constipation. Okay, that was in the few short pages you had. Let me go back. That was in chapter 5 of your med-surg book in the care of the post-surgical patients. There was a small section you need to read, and that was the initial care of the post-op patient. That's where this is coming from. Okay. Review delegation guidelines for LPNs. What kind of clients do you not delegate?
Post-op or not stable.
Not stable. Okay. And when you're delegating, okay, a couple things need to happen. And this includes me when I have to delegate as well, right? You need to give specific instructions on what needs to be done. You need to also instruct on how it is to be done. You need to instruct on what you need documented. And you also need to instruct on what you need communicated to you if they sense there's an issue or a problem. Because ultimately, you are responsible for whomever you're delegating to, and you need to ensure their confidence. So you have to be very specific. Okay, what's to be done? How is it to be done? How is it to be documented? And what do they need to let you know about if they have concerns? And of course, not delegating to an unstable patient. Review discharge instruction, communication strategies with clients and families when they're assisting caring for a family member. So you're doing a home visit. There's other family members involved in caring for the client, right? You're going to have to review discharge communication strategies, what the plan is, if they are going to be participating in the care, right? We need to make it collaborative with the client, right? What are the client's goals? What are their objectives? What are their preferences? What are their desired outcomes? Right? They have to be part of that plan. And everybody also has to be flexible to change up the plan. If they're progressing better than expected, great. Maybe we can move things along. But if they're not, we have to be able to evaluate and adjust the plan going forward. Okay? Does that make sense? Okay. And then you can review these 6 complex chronic illnesses. There's several questions, just so you know, in this area on the exam. Okay, so please read up on. You should have already read up on it as preparation for class, and there are questions on the quizzes. But make sure you have a good understanding of these 6 chronic diseases. Okay. Okay, and then this past week in week 9, some of you, well, Lauren, are you a Friday student? I don't have my schedule up. No, okay, so you've already been in class this week. All right,
Yeah.
so Reese and Anastasia have not. They're Friday students. So you guys need to look if any Friday students are watching this or are watching this recording, you have to go back and review the lecture I sent to you earlier in the week. I sent you my Monday lecture. Okay. You don't want to miss the content. Okay. So part of you not having class this week it's not just like, hey, we didn't have class this week. It's a holiday. You do have to do your due diligence and go back and review that week 9 lecture. Okay. That's your class. Unfortunately for you guys this week, that's your class. It's a recording. Okay. All right. So we talked about human abuse and violence. Here's what is important to know for the exam. Review different types of violence and give examples. So, I mean, I think what we talked about in class was domestic violence, intimate partner violence, child abuse, child neglect, elder abuse, elder neglect, murders, suicide is violence against oneself, assault, family violence, human trafficking, right? That's off the top of my head. Can anybody want to add to that?
Did we say child abuse?
Yep. Yep. Mandatory reporting. What's that?
It's saying that you have that by law you have to report abuse.
Any suspected child abuse, elder abuse, vulnerable adult abuse. You don't have a choice. And it's not just in the work setting, right? We talked about this in class. It's everywhere. The home, your neighbor's house, the grocery store, the park. We are required mandatory reporters in any setting. Okay, one of the biggest risk factors for suicide is depression. Okay, so reread your section on suicide in your book. Okay. But the biggest risk factors are depression, substance abuse, suicidal ideations, other mental health disorders. What are the risk factors of people who abuse others? If you're having to take care of an abuser or work with an abuser, what are some risk factors? Why are they abusing?
They may have been abused in the past.
Or
May have
exposed to watching abuse, maybe of their siblings, maybe of one of their parents. Right? Remember, violence is a form of control. Abuse is a form of control. A lot of abusers have learned that the only way to regain control and keep control is with constant abuse, right? Review the risk factors of children who are exposed to violence, along with key observations when suspecting child abuse or neglect. Difference between physical and emotional. Physical is the inability to provide the basic needs, right? Food, clothing, water, shelter, medical care. Emotional neglect is the absence of nurturing. You're simply not taking care of who you're needing to be taken care of. You're not providing them the developmental, moral compass moving forward. That's emotional. Physical refers to the actual daily needs of the food, the water, the clothing, the shelter, medical. Okay. What do we think? What are some risk factors for kids who are exposed to violence?
They are at risk of being abusers.
Being abusers themselves. They certainly are at risk for a lot of vulnerabilities, a lot of health disparities. Maybe at risk for mental health issues, substance abuse issues, employment issues. Well, we're talking about kids here, so not employment, but kids have lots of risk factors. I saw this over and over again in the schools of the kids that were exposed. I remember when working with people, working with clients that involves violence, individual violence, family violence, intimate partner violence, kids. I mean, you could be working with an actual victim of violence. You can be working with a perpetrator of violence, or you could be taking care of a witness of violence. And all three have different scenarios. Whether you're, I mean, let's say you work in a correctional facility. Think of all the different types of abusers you might be working with there. And you're nobody, we're not going to be immune, irregardless of where we work, what setting we work in. We're not going to be immune to being exposed to victims, perpetrators, witnesses of violence. Right? Elder abuse. Talked about this in class this week. Financial abuse, emotional abuse, physical abuse.
Neglect.
What?
Neglect.
Neglect. I mean, elder abuse is on the rise. It has been steadily creeping up. It's really sad if you think about it. But elders are so at risk for abuse and neglect in so many ways. Right? So if you are a home health nurse, you're a community nurse working with the elderly population, whether it's doing home visits or group education, you need to be very mindful of the risks and the red flags and what to observe with regards to taking care of elderly. Okay. And the last concept we covered was cultural influences, my favorite topic. Culturally competent care. What does it mean to be culturally competent?
To be aware of ourselves, aware of how other people's feelings or how they see the world in their own viewpoint. Just
Everybody's unique, right? It is our duty to provide culturally competent care. Right? As Lauren said, assessing our own issues, if there are any barriers we might have, biases, prejudices, judgments. We have to move through all that. Because in order to provide culturally competent care, we have to be able to see their world through their eyes. We need to be able to incorporate as much of their values, beliefs, practices, thinking into their health plan, right? That empowers them to move back towards independence or whatever their goals are. Okay, that we talk about cultural knowledge, knowing about different cultures, cultural sensitivity, being sensitive to what their needs are because they may be vastly different from ours. We need not be pushing our culture onto others, right? Cultural competence really comes down to being able to look through that lens from them. And in this changing, diverse world, one of the things we talked about in class is throughout your entire profession of nursing, you're going to be working on your cultural competence. It's a journey. It doesn't happen overnight. I'm in nursing 40 years and still developing cultural competence. Right? It's a journey, and it's something that you need to embrace now, early on. Okay, because you are going to be working with lots of different cultures. The second bullet is about, the first bullet is English speaking client, non-English speaking clients. What are best practices, how to effectively communicate with this population. Again, I would reach out like I did in the schools. You reach out to your community liaisons. Okay, there are plenty of community liaisons that are working with communities that are newly integrating into different communities. Okay, how do you build trust with them? You work with those community leaders, you establish trust, establish some kind of communication through trusted community leaders or maybe coworkers that are of that culture that can help along. However you move forward in developing your cultural competence. Certainly language is a barrier, culture can be a barrier. Got to work through all those. Okay. So that's a snapshot of what I want you to be able to know, articulate going into the exam. If you have a good understanding of what we just covered, you will be absolutely fine on the exam. Okay. And if you can't rattle off answers or articulate any of those bullets, go back and reread that section you're reading, or go to that lecture recording of the week it was in and listen to that part of the lecture. Okay. And then, as always, after you do your due diligence of preparing for the exam, you've gone to the reviews, you've listened to the recordings, you've reviewed the content. If you're still struggling with any concepts, set up a time with me. Okay. And we'll go through whatever you're struggling with before your exam. And so Anastasia and Reese, you've got all next week to reach out to me. Okay. Lauren, are you Monday? I'm not going to, no, I'm going to find you right now. Hang on. I'm not going to ask. I have too many students. I'm going to find you. I know where you are on my spreadsheet. Where are you? Lauren, I'm not going to ask you what class you're in. I'm going to find out what class you're in. There you are. Monday. You're in my Monday class. So Lauren, you don't have a lot. Lauren, you don't have a lot of breathing room here. So if before Monday I can meet on the weekends with any of my Monday, Tuesday students. Okay. So if you feel like you need some additional help at the end, reach out to me on Sunday. We can jump on Zoom and we can cover whatever you're still struggling with. Okay.
Okay, thank you.
Yeah. And I mean that, and this goes out to everybody listening as well. You know my expectation. It's been the same way the first two exams. You do your due diligence preparing, and then let's get together after you've done your studying and go over whatever you're still struggling with. Sound good?
Yeah.
And thanks, you guys. Thanks, you guys, very much for taking the time to come today. I hope this was helpful. Was it helpful?
Yes, it was helpful. Thank you.
Great.
I'm
And I
gonna
hope
watch it.
you guys have a really good Thanksgiving.
You too.
Okay?
You too.
All right. Reach out if you need anything. All right.
All right.
Thank
Bye.
you.
Bye. Yep.
Thanks.
Bye-bye. Yep,
Bye.
you're welcome.